anterior vitreous. It may be of infectious and non-infectious etiology. Pars planitis, a specific entity within the anatomical group of intermediate uveitis, is characterized by cells, debris in the vitreous, exudates in the pars plana and peripheral retina with negative systemic workup. Coming to the clinical approach is similar to what as told by Dr. Kalpana in a previous presentation. First, we need to ask detailed history, which is uveitis oriented, and complete eye examination. Then you identify the anatomical location of the inflammation. Then we do the external examination of the patient. Then naming and meshing by Smith and Nassik. Then we need to compare the clinical characteristics with known uveitic entities. Basically, it's a pattern recognition. Depending upon the pattern, you shortlist the etiological possibilities. Depending upon the etiological possibility, we order relevant laboratory investigations and start the patient on treatment. And also we need to monitor the treatment and assess and treat the complications due to intermediate uveitis in the follow-up period. Coming to the pathology, pars plana exudate consisting of fibrovascular layer with fibrocytes, mononuclear infiltrate and collapsed vitreous, inflammatory vitreous cells consisting of epithelioid and multinuclear giant cells. Most often, the patient presents with the history of floaters and blurred vision. The redness and pain is usually absent. The severe vision loss the patient can have if they have associated cystoid macular edema or posterior subcapsular cataract. Rapid loss of vision can be seen if the patient have associated vitreous hemorrhage or the development of retinal detachment. Anterior segment is most often is quiet. They can have keratic precipitates or the AC reaction can be mild. You can see the quiet anterior segment. Slit lamp picture showing the presence of anterior vitreous cells in a case of intermediate uveitis. Posterior segment, they can have vitreous inflammatory infiltrate. This is a must for the diagnosis of intermediate uveitis. Next, we can see the multiple snowball opacities in the inferior vitreous cavity and also near the pars plana region. These snowball opacities are the large fibrovascular exudative aggregates of grey, white or yellow material deposited over the inferior vitreous base. These opacities coalesce to form the snow banking. The commonest complication is the development of the cystoid macular edema in long-standing cases. This can lead to the development of the lamellar full-thickness macular hole, resulting in severe vision loss. Here you can see the classical flower petal pattern, FFA showing the leakage, and the OCT shows the presence of posterior vitreous cells, loss of the foveal contour with multiple hyporeflective cystic spaces with the intervening eye reflective septae suggestive of a cystoid macular edema. Can have focal plebitis and venous dilatation of the peripheral retina. The diagnosis is mostly clinical. Dilated fundus examination with scleral indentation is mandatory in all cases. If the media is hazy or the development of the cataract, to know the posterior segment, we subject the patients for B-scan ultrasonography, which can demonstrate the presence of vitreous membranes or the extent of the vitreous debris. The UBM then can reveal the presence of exudates or the cyclitic membrane in the pars plana region. Coming to the laboratory investigation, which is already highlighted by Dr. Kalpana, in evaluation in anterior uveitis, it's more or less similar. We need to rule out tuberculosis, sarcoidosis and syphilis in almost all the cases. And tuberculin skin test MANTO is done. If the MANTO is more than 15 mm in an immunocompetent individual is considered significant. Chest X-ray, look for hilar lymphadenopathy, and increased serum ACE levels are seen in sarcoidosis. And for syphilis, we need to order both specific and non-specific serological tests. There are cases MRI of the brain for multiple sclerosis, and if you suspect Lyme, we have to order the serology for that. Coming to the systemic approach, whenever we see a case of intermediate uveitis, we need to rule out we are not dealing with the case of fuchs. Most often, anterior vitreous cells are seen in fuchs. The next comes the pars planitis, whether the patients have snow banking or without snow banking. Depending on that, we order the laboratory investigations. If it is negative, it could be pars planitis or idiopathic intermediate uveitis. If the MAN2 negative and chest X-ray shows ILR lymphadenopathy and increased ACE levels and lysozyme levels, could be sarcoidosis, or if the MAN2 is positive, it could be tuberculosis. If the serological tests are positive, can be Lyme or syphilis. If the patient has preponderant vitritis, the toxocera can be diagnosed based on the clinical presentations. In rare cases, we can order serology as well, and could be an endogenous endophthalmitis kind. The next, if the patient is resistant to treatment, we need to suspect lymphoma. If the patient is predominantly vasculitis, we order for MRI of the brain and we diagnose multiple sclerosis. Lyme's disease, the patients can have history of a tick bite with edema migricans and neurological signs, can have vasculitis in the eye. Managed with appropriate antibiotic. Come to the multiple sclerosis, they can have periphlebitis and also the increased risk of, whenever we see a patient with periphlebitis with optic neuritis, the chances of multiple sclerosis is there in the top in the list. Coming to the management, the diagnosis of any systemic infection or the autoimmune disease would warrant the treatment of the same. There is a different schools of thought. Whether the vision is diminished less than 6/12 or less, you treat, or if the patient is associated cystoid macular edema, or if the patient has inflammation immaterial of the visual acuity, we go ahead and treat. That's the second school of thought. The next, early and aggressive treatment is most effective. That is the one commonly we follow. The recommended regimen is a modified Kaplan regimen. The first, whenever you see a patient, you give them the periocular steroid injection. They're not responding, or if you need to bilateral diseases, then you go ahead with the oral steroids, where you have to continue the steroids for more than 2 to 3 months. You add immunosuppressive agents. The commonly used one is a methotrexate or azathioprine. Mycophenolate meftil also gives a promising results, but however it's an expensive drug. Or if the patient is not responding to immunosuppressives, the recommended one is a Pathmamalini vitrectomy. So what we follow commonly in our practice is, you see a patient, you treat them with periocular steroid injections. The second level will be an systemic steroids. The third step is an immunosuppressive agents. The fourth step, now we started using biologicals. Then the fifth one is a vitrectomy. Coming to the complications, the commonest is a cystoid macular edema. The patients can have steroid-induced glaucoma or the development of the posterior subcapsular cataract. In retina, they can have a vasculitis, retinal neovascularization. Come to the case example. A 32-year female presented with blurring of vision for 2 months duration in 2006. She also gave a family history of TB. Her father had tuberculosis and treated for the same. On examination, visual acuity was 6.6 and N6 in the right eye. The left eye was 6.12 and N8. Right eye examination was normal. Left eye anterior segment is quiet. Anterior vitreous showed 1+ cells and vitreous haze of 1+. Fundus examination, there was a cystoid macular edema, inferior snowball opacities and snow banking was seen. Clinically, we diagnosed the patient as left eye intermediate uveitis with cystoid macular edema. On investigation, the patient had strongly positive MAN2 and the ESR was increased. Based on that, diagnosed of a presumed tuberculosis, the OCT revealed the presence of cystoid macular edema with a central retinal thickness of 463 microns. So patient was managed with systemic antituberculous treatment. We give 4 drugs for 2 months followed by 2 drugs for 7 months. Eye comes under extrapulmonary category. So the minimum duration of antituberculous treatment should be 9 months. It can go up to 1.5 years also. And then along with topical and periocular steroid injection was given. The patient received 2 doses. The follow-up shows resolution of the macular edema in the posterior pole. This is the OCT showing the CRT of 246 microns. This is the long-term follow-up after 3 years. The patient had a visual acuity of 6.6 and N6 with complete resolution of inflammation. And with the SD OCT, we have gone up to the Pathmamalini region, which shows the eye reflective retina with a disruption of the RPE choriocapillary complex suggestive of a healed parsplanitis. Here is a second case. A 39-year female presented to us in year 2008. Biscular visual acuity of 6.6 and N6 in both eyes. Anterior segment examination showed the presence of 2+ cells. On systemic evaluation, she had erythematous papular lesions in the skin and also on the face, suggestive of a lupus pernio. Fundus examination revealed the hyperemic disc with multiple snowball opacities with sheeting in both eyes. Investigation MAN 2 was negative. Chest X-ray showed bilateral symmetrical hilar lymphadenopathy with the serum ACE levels of 135 units. Pulmonary function tests were normal. Diagnosis of sarcoidosis was started on topical and systemic steroid therapy. This is a follow-up after 2 months, shows resolving lesions, and there was tapering of systemic steroids, and we have added methotrexate to the patient. Here is an 8-year case of intermediate uveitis who had a vitreomacular traction with cystoid macular edema. Following Pathmamalini vitrectomy, there was a resolution of the macular edema in this patient. So OCT plays a role to pick up this vitreomacular traction. Coming to the points, CD4 and T cells may play a role in the pathogenesis of the disease. We need to evaluate for associated systemic disorders. Indirect ophthalmoscopy with scleral indentation to look for typical vitreous infiltrate and the Pathmamalini exudates. Complications like glaucoma, cystoid macular edema, and development of RD to be watched. Diagnosis is primarily based on the clinical findings. Modified Kaplan regimen is the most accepted modality of treatment. Early and aggressive treatment gives good visual prognosis. In severe cases, visual rehabilitations can be obtained by cataract surgery, and also the Pathmamalini vitrectomy can be done. Thank you for your attention.